Great. So, hi everyone. Welcome to the Tower Hamlets Trauma Informed Community of Practice this September. Happy back to school to those that are contending with that this week. We've got a great presentation today from Dr. Tomazia Galhardo Burnett, so I'll hand over to her shortly. We were meant to have a presentation from my colleague Akramal from the Tower Hamlets Community Education Provider Network, but he's unfortunately unwell. But I'll share some of his material that he was planning to present today, and then we can still have a discussion about the relevant topics afterwards. Before we dive into Tomazia's presentation, I forgot to introduce myself. I'm Angela Burns, and I'm one of the co-chairs of this community of practice. And then the other co-chair is Dr. Patricia Potter, who's also here with us today. We have these monthly learning sessions each month on a Tuesday, covering different topics and sometimes more of a discussion about how we're doing and trying to work in more trauma-informed ways. So if it's your first time here, welcome. And if you've been here before, welcome back. I will hand over to Dr. Tomazia Burnett now. I've got your slides if you need help with that, but otherwise I think you can take it away.
Okay. Hi, everyone. I'm just going to start by sharing my slides and then we can do proper introductions. Okay. Okay. Can you see my slides? Yeah?
Yes.
I can see you, Angela, so I'm just going to take this. Everyone else can see it. Okay. I'm just getting to slideshow. Okay, so good morning, everyone. My name is Tomazia Burnett, and I'm a clinical psychologist working in the NHS. So today, I'm honored to share my research on the issue of trust in public health within Black African and Caribbean communities. Now, this is my thesis research, which has been a little while ago, and it was completed as part of my doctorate in clinical psychology. Today's presentation, I think it'll take about 15 minutes, which is relatively short, but I'll do my best to stick to time. I think we may have some flexibility actually, so fingers crossed on that. But there will definitely be an opportunity to ask questions later on in the meeting during the discussion section, like Angela mentioned. This is not moving. Okay, good. So just starting with a brief overview of today's presentation. So I'm going to start by introducing you to the topic. I'm going to talk you through really my journey to getting to this topic and why I chose it in the first place, and then really hopefully emphasize why this matters. I will then move on to talk you through, my research questions and methodology. So really just give you a bit of an overview of those. I don't think many people are very interested on those bits, so I'll try to be quick on those bits. And then I'll spend the majority of today's presentation talking through the main findings, which is the ecological model of trust in public health, and an application of the model to the COVID-19 vaccination trial. So this is where most of my time will be spent today. And then I'll finish by talking through some of the main implications of this model for public health practice and policy development. Okay. Okay, so my journey into this topic. So my journey into this research began in 2020, a year we will all remember, we were all introduced to the realities of COVID-19. Like many of you, I followed the news quite closely and I saw how Black African and Caribbean communities were disproportionately affected, with mortality rates 2 to 4 times higher than those of white groups. I also remember, quite early discussions that often blamed those differences on things like biological factors and lifestyle choices, really unfairly suggesting that Black people were inherently more vulnerable or somehow responsible for their own outcomes. Now, these narratives ignored, oh, okay, I think someone just joined, isn't it? I think that's the sound I just heard. Okay. So these narratives really, they ignore the deep impact of systemic racism on health, which is well studied. And it wasn't until the Public Health England inquiry that racism was acknowledged as a key factor in COVID-19 disease progression. So now, when the COVID-19 vaccination program was introduced, data revealed that 21% of Black people were hesitant to get vaccinated, compared to just 4% of white people. Again, once again, the narrative at the time shifted to blaming Black communities for not supporting public health efforts. So the government's response focused on combating misinformation and improving health literacy, assuming that the issue really was one of lack of knowledge and lack of, and perhaps a misunderstanding. And I remember feeling particularly frustrated as this approach very much overlooked a history of oppression, and it very much reinforced harmful stereotypes. So, amid all of this, I noticed a significant gap in research. So, while trust in itself, was acknowledged and again was well researched to be a crucial, factor for public health, being associated with things like cooperation with public health measures, community cohesion, there was little exploration into how trust is built in communities with a history of discrimination. Trust in public health is built in communities with a history of discrimination. So this very much motivated me to focus my research on understanding how Black, African, and Caribbean communities in the UK understand trust, what influences trust, and the role of trust in public health for these communities. Okay, so my research really aimed to answer two questions. So the first question was, how is trust conceptualizing Black communities? And then the second question was, what is the role of trust in public health for Black, African, and Caribbean communities? Now, to answer and to investigate these questions, I interviewed 15 people from Black, African, and Caribbean backgrounds. I employed, what is called the critical grounded theory methodology, which essentially would just allow me to understand the lived experiences and the perceptions of public health of these individuals in a very nuanced way. And grounded theory as a methodology really allows you to start without any assumptions, which I felt was very important here, letting the data shape my analysis and leading to new theories and understandings. Okay, so the result of these interviews and data analysis is the ecological model of trust. So this is the model you can see on the right side. It provides a comprehensive understanding of how trust is established, how trust is maintained, and sometimes lost in public health for Black, African, and Caribbean communities. So the model illustrates that trust in public health, as you can see, is complex. It's multidimensional, especially for communities that have historically faced discrimination. Trust is not straightforward at all. It's a dynamic process shaped by historical factors, political factors, community factors, and individual factors. So if we examine the model a little bit more, it suggests that at the broadest level, as you can see right at the top, trust is influenced by deeply ingrained historical societal issues, things like colonialism, systemic racism. These factors form the basis of how trust in public health is developed on a large systemic scale. Trust is also very closely linked to political systems. So, trust in public health is connected to people's trust in political systems. So, community views of public health often reflect their perceptions of political leaders and institutions. This means that trust or mistrust in one area can influence the other. On a community level, shared experiences within the community are key. They're very crucial in shaping how people perceive and they interact with public health services. And on an individual level, personal experiences with healthcare, they further impact trust. So negative experiences, things such as discrimination, can lead to lower trust levels, causing individuals to seek public health services only in emergencies. In contrast, positive experiences, where individuals feel heard and supported, they foster higher trust and they promote a more proactive, engaged behavior in public health. Now, this proactive engagement is essential for the success of any public health initiatives. So this overview obviously touches on the core aspects of the model. I can probably spend a lot more time there, but I'm going to try to focus to talk a little bit more key findings from this model. I do encourage you to go back and explore it further. As I said, it is complex, but it does offer valuable insights. So the first key finding, as you can see there on the other side, is that, what I mentioned before, trust is not static. It is complex, it is multi-layered, and is constantly evolving, shaped by various factors. The second finding is that trust is a collective, community-led process, shaped by personal experiences and shared experiences within the community. So communities are very important, and this was one of the biggest findings really from the research. Communities that create safe spaces for individuals to share and process their experiences, to access essential support, and all of this is absolutely key for building and sustaining trust. So the collective understanding of public health that happens within the communities influences a lot how they now engage with public health services. The third finding is that trust is built over time. As I mentioned earlier, trust develops slowly and is heavily influenced by things like historical trauma and historical injustices. So this means that mistrust is actually a rational response and not an irrational fear at all. And this enduring systemic mistrust affects how people currently engage with public health services, making it harder to establish trust in the first place. So, to really effectively build trust in public health, we need to acknowledge, address, and understand this historical context. The fourth and final finding is that personal experiences create what I call a feedback loop. So the model suggests that positive experiences can help to build some trust, while negative experiences can deepen existing mistrust. So this creates a cycle where our experiences continuously, influence our feelings about public health, making trust really, really complex to study. So that means the negative experiences in particular, they not only deepen mistrust, but they also create fear, causing people to avoid using services and only seeking help in emergencies. Whereas positive experiences with public health providers can build trust. Now, this trust, well, one of the findings from the research is that distrust is often limited to individual providers, so that GP or the healthcare professional they work with, and does not address wider systemic mistrust. So some participants reported feeling really confident in that specific, GP provider, and at the same time they spoke about remaining overall skeptical about the state of public health. This individual trust is quite fragile and situational rather than a solution to broader systemic issues. Okay, so now in this slide, so actually, let me just do a brief pause. Hopefully, everyone is still with me. Yeah? Okay. Okay, so now in this slide, I'm showing an application of this model to the COVID-19 vaccination drive. So by using this model, we can gain a clearer and more nuanced understanding of how vaccine hesitancy among, Black African and Caribbean communities, and highlights how deep-seated mistrust has influenced their vaccination decisions. So if we look at how this model was applied to the COVID-19 vaccination drive, one of the main findings was participants discussed that they were hesitant about the COVID-19 vaccine due to long-standing mistrust. So this mistrust wasn't due to misinformation, like all the approaches were suggesting. It actually stemmed from a deep understanding of historical exploitation and the mistreatment of Black individuals in society, as well as in medical research and generally like worse outcomes in public health. Even though many participants understood the vaccine's importance, so they had knowledge. So some of the participants, they were, nurses and they were researchers and they were scientists and they had really deep understanding of the vaccine and how it works. But they spoke about feeling quite skeptical. And that was a lot to do with that distrust of the government and distrust of government actions, which they viewed as self-serving. Family and community opinions were crucial in vaccine decisions, so they often outweighed government advice. In communities as well, they provided vital support and resources, creating an environment that people felt really self-empowered and an environment that allowed them to resist coercion that was happening at the time. And many participants felt, compelled to vaccinate, um, not out of, not out of trust in the vaccine or trust in the government, but out of fear and to avoid discrimination and to keep their jobs. And these negative, what I call here actions hindering trust, this increased their skepticism and it led to anxiety when it came to engaging with public health. And this really emphasized the need for public health strategies to address deeper issues rather than just implementing surface level interventions. Okay. Okay, so now in this slide, I'm talking you through some of the main implications of the model. There are many implications, and I couldn't kind of put them all on a slide, but these are some of the main ones that I think are worth kind of taking away. So the first thing to mention is that, the historical context awareness, addressing mistrust in public health requires acknowledging the historical and social contexts of oppression and colonialism and its lasting effects. So we can't really build trust in public health, and we know how important that trust in public health is for public health outcomes, but we can't build it in the first place without acknowledging the context, that historical context, and the impact it has on people's, quality of life, experiences of services. So without addressing that, we cannot even start to build some element of trust. So the other implication to take into account is that it's a long-term commitment. So developing trust in public health is a process that is, as we were able to see, influenced by many factors. To build trust, we need to focus on genuine community engagement rather than seeking quick solutions, which are likely to be both ineffective and harmful. It's a process of developing lasting relationships to address something that is systemic in nature. Okay, so mistrust in public health is a systemic issue. And trust in public health is influenced by many factors again. So improving trust public health outcomes requires more than just single issue solutions. So instance, so if we think about the vaccine hesitancy and the approach which was to tackle that using health literacy alone without considering broader issues like historical injustices, not only was it, for some people quite ineffective, but also counterproductive. So to create lasting change, we need to implement multi-level strategies that address the root causes of mistrust and engage with diverse communities. And like I said before, the community aspect is a key, is one of the main implications of this model. So building trust in public health requires community-centered approaches. So by engaging with and tailoring interventions to the specific needs of each community, we can create more effective and equitable health strategies. So this means partnering with communities, ensures that public health efforts are more inclusive and they address the complexities of collective experiences rather than focusing on addressing specific individual needs. It's crucial that public health initiatives respect and align with communities, and that means also aligning with their cultural values to make sure we're not implementing practices that are harmful and that do build trust over time. And very much in line with this, this space, this forum that we are in today, my findings suggest that trauma-informed practice is very key. So one of the things to hold in mind is that something that we hear often in services, disengagement, people essentially not engaging with services, avoiding services, dropping out of services. So this model in itself suggests that disengagement should not be viewed as a personal failure, but as actually as a protective response to systemic mistrust. So this means rather than labeling communities as hard to reach, we should really work towards adopting trauma-informed approaches that prioritize things like safety, choice, respect. These actions, which were all recognized by participants as positive actions, they can help to foster that individual trust that we spoke about, but they also help to address the root causes of systemic mistrust. And then the final bit, which is probably one of the biggest bits, is decolonizing public health. So the current study and the model really agrees with the growing body of research that suggests the importance of decolonizing public health. So decolonizing public health is about making healthcare fairer for everyone, especially those who have been overlooked. This means changing how we study, how we research, how we teach, how we practice health, to eliminate old biases and to include, a variety of voices. This means incorporating non-Western approaches, revising our health curriculums that we know that's been taught, ensuring that the policies are evidence-based and not just politically influenced, and ensuring that marginalized communities are central to health strategies. And there's a fairer, and there is a fair representation and a critically informed approach to what we do. Okay, and that's me. So thank you for listening. Any questions? And then towards the end, I've got here some references in terms of the research. So if you're really keen to hear, to read many, 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 many pages, yeah, you're more than welcome to go and access that link and then, yeah, read the rest of the research. Okay.
Thank you so much. That was very well summarized, given that I know how much has gone into a project like that, and you've covered quite a range of topics. So I imagine that interviews themselves must have been really interesting to conduct. Opening the floor for questions about the research or the implications. Any initial reflections? Perhaps while you're still thinking about it. And yeah, if you could pop the link in the chat, that would be great. Otherwise, I will share the slides with the whole mailing list, so you'll receive a copy from us of Tomazia's work and the publication itself. Over to Patricia.
Hi, I just thought I'd get things going with a question. Really, really helpful research, and I remember at the beginning of the pandemic, if we'd had this as kind of in such a clear way, I think we were grasping and kind of catching wisps of this, but didn't have that sort of, even though we were thinking about a kind of ecological frame of health. So thank you very much for doing this really important work. My question is, you're sharing this with us now, which is great, and I'm guessing you're writing it up for publication. But have you been able to engage with our public health teams? Like, I clearly there's a link into our Hamlets, but have you been able to do that? And have you, if you have, what feedback have you got from the public health teams?
That's a very good question. So just to say, the link is there now in the chat. Yeah, and thank you for the comments. They're very lovely. In terms of kind of engaging with public health teams, so I haven't had an opportunity to engage with public health teams. So during this research, I worked alongside, some community organizations to really think about the research. And my focus was always sitting within the community. And once the research was complete, really, the focus is now to kind of feeding that back into the community in the first place, and then public health. So this is kind of part of the future work. So if you have any suggestions and links, I'm happy to hear about those. And who to contact and to engage with. Yeah.
I can think we actually have a journal club in our team, so that can be your first stop. Got some hands
and sorry,
up.
and just to say, I've shared this invite with the public health consultant in Elft, and she's very interested. So you might be contacted by one of her registrars.
Perfect. Over to Brian.
Hi, really interesting presentation. Thanks a lot for that. So one thing I noticed was not just during COVID, but since the impact of social media platforms, WhatsApp chat groups, TikToks, and they seem to be key for spreading misinformation amongst the Black African and Caribbean communities. So my mum is part of several WhatsApp groups, and every now and again I'll get a WhatsApp sent to me and she'll say, does this look legit to you? And, you know, from someone who knows a little bit about some things, you're like, that clearly doesn't look right. But, you know, you've got people who already believe that the system is stacked against them, that who already believe that the government sees people of color as second-class citizens and are willing to use expired vaccines. And what, you know, these stories go around. And I mean, unless there is a strategy, I mean, my question was, is there a strategy focusing on how to address this misinformation, specifically about health and medicine issues? I mean, obviously there are wider issues about other topics, but I think for health and medicine in particular, there does seem to be something within the Black, African and Caribbean community that makes trust very, very hard to come by.
I mean, you've made so many great points. I don't even know where to start. Yeah, so I guess starting with the misinformation bit. So previous research has really shown that even when there is misinformation, if there is trust, people cooperate with public health initiatives. So that means that actually by focusing on just misinformation, we are missing out the big context of trust and in the power of trust when it comes to deciding things such as either going to your GP or accessing health in a proactive way or taking a vaccine. So misinformation is important, but actually it's a lot really ingrained in that aspect of trust, And when I spoke to people, I think your point about your mom and the WhatsApp groups is a good one because when I was having these interviews and people were telling me about some misinformation going on there, that misinformation was still contextualized in that views of the government, in their views of public health, in the setting in which they felt, and the history really. People had great awareness of history, have not forgotten about the impact of colonialism. They have not forgotten the impact of that in developing, the current public health system. The knowledge that is in the public health is based on, very, colonial ideology, still very much informed by that, So people had a great understanding of that. So again, that misinformation, whilst relevant, is still feeding back into that aspect of trust as a wider topic. Does that answer your question, Brian?
Yes, that's brilliant. Thank you.
Yeah. And I guess the second thing you said in terms of, where do we go here from now? My research wasn't trying to answer all the questions. So the first thing I'll say is that, the process of, deciding where we go from here is a collective process. And that's really what comes out of the research. We need to take community-led decisions. We need to really do that as a collective process rather than getting one individual person or even individual research answer all those questions. But trust must be addressed. In fact, actually, mistrust must be addressed because mistrust is the status quo, and that's, again, what the research says is that people, and again, from that collective understanding of, public health, they already hold mistrust. So unless we address that mistrust by, maybe stop forgetting about the past, brief idea there, changing some of the, the knowledge systems, dedicating more research to Black bodies. There's a lot of things that we could do. And then on an individual basis, again, the research says that there's things that we can do in terms of providing people positive experiences in public health that will have an impact. But that action in itself, so it means like if you go to your GP, have a good experience with your GP, that is not enough to address systemic mistrust. So it has to be multiple levels that are being addressed at the same time. So it has to come from the top. So rather than expecting people, and includes, getting communities involved. So thanks, Brian.
Well said. We've got a question from Kavita next.
Hi, thank you so much. This was really, really interesting and actually made me realize that I've bought into some of those narratives and I really appreciate an opportunity to challenge my biases and deconstruct them. So thank you so much. And it's really helpful to have the actual reason as opposed to the reason that it looks like on the surface. I work at Queen Mary at the university and we obviously have a really diverse student population. And I wondered, I know you only interviewed about 15 people, but did you see any specifics around age and particular age groups in terms of differences in terms of how they viewed this stuff. I mean, obviously, it's that thing that you were saying was really powerful. These are stories, like people's experiences have been passed down generation after generation. I think particularly around medical and health, the experiences of Black people have been horrific, and of course they remember those things, and the mistrust has been, it's been deeply, deeply ingrained, and it's how, you know, we share those stories to keep ourselves safe, and that's what those groups have been forced into doing. But it would be really interesting to hear if you had any experience of speaking with younger people about how they perceive some of this stuff.
Yeah, so this was qualitative research, so not a lot of people, so 15, but I did have a good range in terms of ages. So we had people as young as, 20 joining, kind of, yeah, which I did interviews with, and the oldest person, I think it was 60. So again, we had a very wide range of ages
Angela,
there.
can you do me a favour, just shut the door? Thank you.
Okay. So we had a wide range of ages there. And we also had race is not uniform. I mean, yeah, people are, when we think about what Black African means, what Black Caribbean means, when we think about the experience of being mixed race, there's a lot nuance in that, So there was some variety. So I definitely did see, people particularly, not so much to do with age, but when it comes to do with closeness to whiteness, if we put it that way, so people who were mixed race did speak about having more positive experiences with public health. However, that systemic mistrust meant that they still did not hold trust in public health. Again, they had even those positive experiences, they were not sufficient to combat the messaging, that systemic trauma that is there, So I guess, I think when it comes to age, there wasn't as much of that difference as struck as there was when it comes to different racial identities. Hopefully that answers your question as well, Kavita.
And I guess too, there's a lot more to people's familiarity with health than age. I suppose things like education and all of that. And I guess that relates also to the kind of closeness to whiteness thing that you mentioned.
And education was another thing. So it's another demographic factor that, I took hold of, because again, the idea was that because people didn't understand the vaccine, that's why they were making those decisions of, being hesitant and choosing not to vaccinate. I had the variety people from, different sets of knowledge and professions, and it was really clear that a lot of people did understand the vaccine. Some people had some misinformation going on, like Brian said, but a lot of people really did understand the vaccine, but they still didn't trust the government. Again, it was more in-depth, more
a really good distinction. Thank you. Next, we've got Wilma's question.
Thank you so much. Really, really interesting. I actually have two questions, and it might be, I don't know if you can answer them, but I'm just going to post them. One is, so I work in a GP surgery, and I felt that, even though you're absolutely right, these individual kind of conversations with people are not enough. But do you have any suggestions of how I, as a white woman in a GP surgery, can, when we do have those brief encounters, because I felt I could not always kind of overcome the schism that was there, and I also almost like out of respect for, look, who am I to indeed, I already felt inadequate, but then I also didn't get anywhere sometimes in trying to move forward with that kind of, oh gosh, we're just in such different worlds. And I don't know if you've got any practical tips or ideas. And then the other question is, and that's just possibly just a massive blind spot, but that I have, but could you give one or two examples of where you see the colonialism in public health? I'd love to kind of be able to hold on to that in my head, but I need to kind of an example if you have one. Thank you.
Okay. So now I'm thinking about the second question if we're getting the first one. So remind me of the first question before I answer it again.
So the first question was, do you have any practical tips or
Yes.
ideas when you have that brief encounters with people?
Okay, I'm with you now. Yeah, so I think that's where the trauma-informed really comes in. That's where trauma-informed care comes in. And trauma-informed care is not new. It's again, there's a lot of communities, there's this space really. But the research shows that, again, those positive experiences, whilst they're not significant enough to address systemic mistrust, which needs to be a systemic level of addressing, but individually, if we adopt things like, again, the basic things that we hope to see, recognizing people's, personal experiences and histories, making sure people feel safe, feel respected, following up on the things that we do, giving people knowledge. So again, some of the things that people said is I go to my GP with, and I do so much research even before I get to my GP. And that research is to protect me because I know that, if I have this knowledge ahead of time, it means that if they say something that I know is incorrect, I can protect myself. But also it means I can or I can advocate for myself when it comes to going to those spaces. So I really receive the best care. So it's a lot of work. It's a lot of emotional, like intellectual laboring that people are putting to be able to just attend a GP appointment. So being able to, again, provide people knowledge and just following up with the things that we do, again, those trauma-informed care principles are really, really key in building some individual trust and really, hopefully, getting to address some small aspect of that systemic mistrust. So that's the first thing to say. And then in regards with your second question in terms of, again, what was the second question? Remind me again. My mind is kind of running a little wild there.
No, I completely get it. So if you can give any examples where you saw the colonialism in public health.
Yeah. So I think it really comes into public health knowledge. So knowledge, for instance, there's limited research when it comes to how vaccines work on Black, African, and Caribbean communities. So that's one of the things. So during the pandemic, people may remember about the French scientists. Does anyone remember about the French scientists? No? Yeah. So that was, at the start of the pandemic when we finally had the vaccines. So there was an idea suggested by French scientists that we should just go and test the vaccines in Africa. And again, the idea that, that again, this idea that actually in this, when we know in terms of history, by Sabrina, when we know in terms of history, is that in the past, Black, African, and Caribbean communities were used to do things like use kind of testing vaccines. And again, we can talk about AIDS, and there's a whole aspect of that there, but there's a lot of history when it comes to Black, African, and Caribbean communities being used in medical research in particular. So that distrust was really connected to that understanding. And the reason why Black, African, and Caribbean communities were used in medical research is because, again, colonial ideas about being, again, not being as much of a human compared to white people and not being able to have as much knowledge as white people. Again, so that is very much informed in that. And having a different brain, again, so race not until few decades ago, was still seen as a biological thing. There was biological reasons why people were different from each other, where there's so much research to show that race is not biological at all. Again, race in itself is a social construct, so it's developed, by, narratives. So hopefully that answers your second question now.
Thank you. And I think that's a really good question. I'm sure that there are hundreds more. I think one that comes to mind that speaks a bit to your choice of research methods is the kind of like different ways of knowing, or what we consider to be science and scientific knowledge. And I think the choice of using grounded theory as opposed to something where you're applying kind of existing themes or existing ideas to what you're hoping to find made sense in that case.
Yeah, that was exactly why I chose grounded theory, because there was not enough research and enough knowledge, and the knowledge that was there, it was already missing out on these communities. Mm-hmm. Yeah.
Great. And then we've got a hand from Sadikar.
Hi, good afternoon. running low on battery quickly. Yeah, I know you said a 21% in terms of hesitancy in the Black community. I don't have the stats, but we know it's quite general public knowledge now. The death rate was much higher in the Black and ethnic communities. Do you think that further reinforces mistrust?
Yeah, I do. I think that makes sense, doesn't it? Being able to, again, when you see people who look like you, people who are part of your community being so disproportionately affected by a disease, and now you're being sold this idea of a vaccine, you probably feel less trustful towards that vaccine. So I think that it's a very good question, really, and I think it does. It's not a question I ask, so it's a question the future research can really go there and ask more, but I think it does make sense, sounds logical.
Thank you. It makes sense that what people observe, regardless of if it's directly related, that they would feel it. Like it's not like we exist in a kind of vacuum. So it's a very good question. I wanted to move on slightly just to really briefly reference the project that Ekremel from GP Care Group is going to present. And it is related to this because there's been work going on locally in Tower Hamlets to improve the, I guess, competencies around anti-racism. And so there is a bit of a work plan across our integrated care system, so mainly focused on health and care services. And a big focus of that, like many other areas, is initially around workforce development. So I have a really brief video about the training that they implemented and the kind of feedback from it. It's just not even 2 minutes long. So I'll share that. And I think perhaps there might be some questions or discussion after around local practices that maybe your teams have been applying or that you want to explore around trying to be a more anti-racist place to encounter in terms of health and care. So just bear with me. I'm gonna make sure that I include sound and choose the right window. Okay. Okay, hopefully people could hear that and see that okay. Of course, I can't do Ekremel justice as far as explaining the detail of the training, but he did send over some slides that I'll include afterwards. So that training was running during the last financial year, so up until April, and it may be that they decide to offer more, but obviously training is always only the kind of first step of any like system change on anything. So I expect that there will be other steps that they're looking to take. But I wanted to pose a question to the group, kind of coming off of what Tomazia was initially, I think, answering from Wilma's question, but any practices or things that your teams are trying to do differently in order to address issues related to like anti-racism, colonialism, equality, diversity, all of those buzzwords. Any examples that you'd want to share with the rest of the group? Can also be a challenge or something that's come up recently. I know, of course, we've had like racist riots going on across the country that have felt quite alarming as people that have to go to work as well. So it can be, you know, initial responses to that as well. Go ahead, Brian.
So I think within homelessness, we seem to be struggling to address the fact that every community believes that they are being disadvantaged to the advantage of every other section of the community. So basically what we're trying to do is communicate to everyone that no, you're not being targeted because of your color. The situation is equally bad for everybody. You know, no one is getting any better than what you're getting. Everyone is staying in these hotels with no washing facilities, no clothes washing facilities, no facilities to heat milk, or you know, that's the reality for everyone in temporary accommodation, which isn't a particularly great message to have to deliver, but it does, we hope, at least make people realize that no one's getting special treatment, because everyone thinks that someone else, everyone hears a story or can relate a story of, oh, my neighbor's mate came in and they got this and they got a house within 6 months. You know, these stories abound, but you know, they're all nonsense, and you know, it is just communicating, but trying not to be too negative about it, which is difficult to do when the options are pretty limited, you know.
It sounds like a really tough one. I think too, it doesn't help that certain communities are more likely to be on those lists than others. So I suppose there could be something around that. But yeah, that sounds like a really tough kind of message to respond to. Thank you for sharing it. Other colleagues, other challenges, or any further questions for Tomazia? If not, that's completely fine.
Angela.
Oh yes, go ahead.
Yeah, hi. So I thought of a couple of questions, not questions that you have to answer right now, or anyone has to answer right now, but something just to leave people with to think a bit, holding in mind the model, holding in mind the findings, so they can kind of come back and look at those questions and see if they can come up with something that they can do in their practice. So the first question was, what stood out to people when they heard about trust in public health and the model presented? Any key factors that stood out to them? Because I think there's many different aspects to it, but what stands out for you probably says something in terms of what might have been a blind spot or a challenge for you. And then the second one, how might this model apply to some of your work? So in terms of if you were to apply it in psychology, sometimes we call it in a formulation type of way. And if you were to really think about, the client group of people they come into your service, holding in mind, what is their history, how they might, what is that relationship, the current political systems, what is the role of that community in how they see themselves, how they see public health, and then thinking more about the individual experiences and what is going on. Are we acting in any ways that are, negative and hindering that trust, but yeah, so I thought about just those two questions. I can put them in the chat if it's helpful. just
Thank
to
you.
leave
That would be
people with.
great. I can see a hand from Nina. Would you like to come in? Sorry, you're on mute.
So sorry. Definitely very helpful findings to keep in mind and remind myself how important it is in my little job as part of the systemic, the whole systemic, what is it called now? Systemics. Sorry, I lost my words.
System.
Within the system, when I try to be compassionate and I have sometimes very angry service user or people who draw on care and support, I'm a social worker. Sometimes to kind of put it in a context of this is a protective response, and sometimes they want to disengage with you and they're very angry. It's a part of the systemic mistrust. And I think I really, really adopt this concept, and I can see that in my work every day. So my capacity to provide compassionate care when people are angry with you and complaining about you and want you sacked, I think that trauma-informed care will be really helpful for me to try and remember and lift myself out of all this, to view it from a bigger perspective. Thank you very much, Tomazia. Thank you.
Oh, that was so beautifully put, Nina. I love that.
Thank
And I
you.
think there's definitely something about recognizing that sometimes this is the people who are trying to do genuine work. It can feel really, really, it's empowering, and you can feel very powerless. And sometimes when you have those encounters and it doesn't go well, you can feel like it's about you, it's about all the work that you're doing, so we can all really internalize the experience. But the model really says, again, mistrust is the status quo. People they automatically mistrust because of all this knowledge, and that's systemically founded. But also says that what we do can matter. It does matter. It does matter in the long term. Maybe that first interaction is not sufficient, but in the long term, it can really make an impact there. But also suggest team decisions rather than individuals. So not hold it just yourself, Nina. Go back to the team. What can we do as a team rather than thinking, what Nina can do to address this?
I think that that's a perfect way to end and sum up so much of what we're trying to do as a group. Thank you again, Tomazia, for a really brilliant presentation. I think lots of us have, got even more food for thought after the discussion. So thanks everyone for your questions. We'll see you again in October. We've got 2 presentations lined up that are focused around working with people who've experienced homelessness. So hopefully we'll see you then. And I'll send out the recording and slides probably today or tomorrow. So again, thanks for joining and have a great rest of your day.
Thank you.
Take care.
Thank you.